Hello, I'm Hematologist Oncologist Dr. Tony Talebi. Today we're going to discuss prostate cancer. I have the pleasure of being with Mark Soloway, Professor of Urology, University of Miami, former chairman of 20 years, and truly an internationally renowned urologist. Pleasure having you.
My pleasure. Happy to be here.
Thank you. Dr. Soloway, what is prostate cancer?
Prostate cancer obviously is a malignancy of the prostate gland. It's the most common cancer in men in the Western world, United States, Canada, Europe, surpassing lung cancer. It is a malignancy of various grades of the prostate. It's an adenocarcinoma. I think that would be succinct. The prostate gland, of course, is the gland that's situated between the bladder and the urethra. It surrounds the urethra. Main purpose is to produce the seminal fluid, which is stored in the seminal vesicle attached to the prostate. So for fertility, if you want to have children, you need a prostate. That's the nutrient. Most of the seminal fluid, the ejaculate, is made in the prostate. It requires testosterone, male hormone, to grow, and it tends to enlarge as men get older. So they have urinary symptoms, frequency, getting up at night, slow urinary stream. It is fairly common, but that's not cancer. Prostate cancer usually, certainly in the modern era, in the last 30 years, has no symptoms when it's diagnosed, as opposed to advanced stage. Then there are symptoms because the cancer can cause the prostate to grow as the cancer enlarges and encroach upon, narrow the urinary stream and make it difficult to urinate. But by far and away, currently in the US and Western Europe, the disease, prostate cancer, is diagnosed by the PSA, the blood test.
Why is the incidence on the rise, at least in the United States?
Well, the incidence is on a rise clearly because of early detection, because we have a marker that tells us who has prostate cancer. Before the PSA, or prostate-specific antigen, a blood test, then most people were diagnosed, most men were diagnosed because the prostate felt hard or it had already spread, which is true in some countries like Jamaica, Bahamas, which is close to us. It's still the case because they don't use the PSA for early detection. But if the PSA, when it started to be used for early detection and men were biopsied who have no symptoms, then the incidence shot up because probably 30%, at least 30% of men over the age of 70 have prostate cancer. But for the great majority of them, that prostate cancer will never reach this stage or the aggressiveness with which it will spread.
I see.
So they won't know unless they have a biopsy.
So what do the prostate numbers mean? I mean, the different ages have different numbers. What does that exactly mean for each particular age group?
You're talking about the PSA now? Okay.
Yeah.
Well, the PSA, again, or prostate-specific antigen, is a blood test, easily performed, many labs perform it, simple blood test, in which there are several factors which allow the PSA to get into the bloodstream and therefore cause an elevation. So one of them is infection, one of them is simple enlargement of the prostate, and the third is prostate cancer. Those are the main ones. So let's say the PSA is 5, just to pick a number. Normal is, there's no real normal, let's start out with that, but roughly we say between 2.5 and 10. Anyone with a PSA between 2.5 and 10 has a 15 to 20% chance of having prostate cancer found on a biopsy. So that's an important figure. Probably increases a little more as you approach 10. Once you get up to 20, 30, 40, it's probably 50%. But this day and age, we don't see very many men with a PSA above 10 because many men are getting PSAs regularly, and by then they would have had a biopsy. So if one has a PSA, as I said, let's pick 5 or 6, then what I would do is sit down with that individual, see if he has any symptoms that relate to infection. Usually the answer is going to be no. Does he have a large prostate on exam? Or you can do a transrectal ultrasound and measure the size of the prostate. So if the prostate is normal, which is 30 grams, and the PSA is 6, that's worrisome. More likely he has prostate cancer than an individual with a 60-gram prostate, twice normal, with the same PSA of 6, because the BPH, the benign prostatic hyperplasia, is elevating the PSA. Not necessarily, but it might be. So therefore, when one has a, quote, elevated PSA between 2.5 and 10, then one needs to take these other factors to then say to this gentleman, you have a 1 in 5, you have a 1 in 3 chance of having prostate cancer.
In Europe, I understand PSA is not even checked on a regular basis, yet the mortality of prostate cancer death is the same as the United States. What do you think about that?
No, that's not true. I mean, I've been Europe many times. I know the people there. Medicine in Western Europe, and actually now most of Europe, is very similar to here. So early detection with PSA is clearly utilized as much now in 2011, 2012 as it is here. And most diagnostics, most people with the diagnosis of prostate cancer also are picked up at a non-metastatic stage in Europe as is here. Now, in areas of the world where, as I mentioned, there is not an early detection program, that primary care physicians don't obtain a PSA every year or two, or look at family history factors, or if they're Afro-American, these are risk factors, then the number of people with prostate cancer is less, but it's a more aggressive disease when found, usually not curable.
I see. Are there any risk factors that predispose one to developing prostate cancer?
As I alluded to, so first, family history. If one's father, brother had prostate cancer, clearly they're much more likely, 3-4 times as much. Age, as we already indicated, the older you get, the more likely to have prostate cancer. As an overall globally, it is said that 1 in 6 men living long enough will have prostate cancer. Again, not all of them will need treatment. So we said family history, age, Afro-American is a risk factor.
Would you please explain what a prostate biopsy is and how it's done?
Sure. Prostate biopsy is an office procedure, as a rule. The individual, the man, has some antibiotics taken up front. We place them in the lateral decubitus position, which is lying down on a table. And we take a probe, an ultrasound probe. It's placed in the rectum, atraumatically. That's not terribly difficult. It's a relatively small probe. Then we can see on ultrasound the prostate. Something I was instrumental in developing is called the periprostatic nerve block, in which we then take some lidocaine, xylocaine, like a dentist would do, and put it around the prostate, wait a couple minutes, and then we take a rapid fire gun and we target individual spots in the prostate, taking from each side of the prostate somewhere between 4 and 6 or 7 biopsies, so a total of somewhere between 8 and 12 biopsies. And again, we keep the patient on antibiotics, keep the man on antibiotics for a few days. The morbidity is quite low. There's a 1% chance of sepsis because of E. coli resistance. But it's a pretty straightforward, if the block is done properly, minimally uncomfortable procedure.
If someone is working or playing golf or tennis, how soon after can they get back?
Right away.
Oh.
They come in, they drive home, not a big issue. They're usually jumping up and getting dressed within minutes.
Very nice. Would you please explain the basic stages of prostate cancer for our patients?
Sure. So most people, let's use the TNM system. Again, as I indicated, probably in my practice, I'm a urologic oncologist, so I see a lot of men with prostate cancer. Probably 85% are T1C, which means I can't feel anything abnormal in the prostate. T1C. You might feel a subtle abnormality, then it would be T2. So clearly 90% are T1 or T2. If you can feel a firmness that might be outside of the prostate, that's T3. If it's extensive and maybe the bladder is involved or it's clearly well off the prostate, that would be T4. Now, the N category is if the lymph nodes are involved, and that would be picked up either at the time of surgery, when you remove the lymph nodes, the pathologist inspects it, or on a CAT scan or MRI, but then it would be confirmed by a needle biopsy. So that's the N stage. It would be N negative or N positive. And then M is metastatic disease, and as I indicated, this day and age, only about 2 or 3% of men that I would see in my practice would come in already with metastatic prostate cancer.
So when would you use an MRI to look at the lymph nodes around the prostate?
Well, an MRI and CAT scan, first of all, would not be helpful if someone's PSA is less than 10. Almost never is a bone scan positive or an MRI or a CAT scan going to be useful. They're way overused if the PSA is less than 10. Unless maybe if the Gleason Score, well, let's go into Gleason Score briefly. The pathologist, once we have a biopsy, grades the cancer. The lowest grade is a 6. So it's two components. The grading is number 3, number 4, and number 5. And we take the most common and next most common grade. So the lowest would be 3 plus 3. The next would be 3 plus 4. 4 is a little bit more aggressive cancer cells. 5 is very aggressive. So if someone has some 4 but mainly 3, it's 3 plus 4. If the 4 is dominant, then it's a Gleason 7, being 4 first and 3. It could be 7, 3 plus 4. 4 plus 4, 4 plus 5, etc. So 8, 9, and 10 are quite uncommon. Maybe 5 or 10% of the total mix is going to be a very high risk Gleason 8, 9, and 10. So you might want to do a scan, bone scan, CAT scan, or MRI in those with 8, 9, and 10. But the great majority, all tests looking for metastatic disease will be negative, unless the PSA is well above 10.
I see, so that's the time. Is there ever a time when it's appropriate to seek genetic counseling if you've been diagnosed with prostate cancer?
The answer, I would think, would be no. I don't think it would be very useful. Now, again, I think one should be aware that family history is important. So if one has several sibs that are male, obviously, then I think they should be told, so I have prostate cancer and you're at greater risk. If your father had prostate cancer, you should start having a PSA and rectal exam probably at the age of 40 or 50 on a regular basis, because you're at more of a risk and you want to identify it earlier rather than later.
I see. We'll discuss this in much more detail in the upcoming video, but assuming a patient had an elevated PSA, they get a biopsy, rules in prostate cancer, what generally happens next for that patient?
Well, first of all, I hope the physician making the diagnosis says to the man, and usually his significant other is there, and this is not an emergency cancer. This is not acute leukemia. This is not lung cancer. It's not pancreatic cancer. Nobody with prostate cancer identified with a PSA less than 10 or 20 is going to die within 10 years. That is almost, you can bank on that. So there is no emergency, because everybody, when they hear cancer, I don't care what kind of cancer, except maybe skin cancer, they think within the next year I'm going to die of cancer. So that takes a while to reassure them that that is not the case. They have ample time to consider the alternatives. And so that's, I think, the important first step. Then one takes into a lot of bits of information. What's the age of the individual? How much cancer was there? What's the grade of the cancer? What does the rectal exam feel like? Does the patient have any other medical problems like diabetes, obesity, that are much more significant in its health risk? So you need to get a global picture. What's the PSA level? All of these things must be put into the equation. What is best for this individual? What is his age? How important are erections to he and his significant other? All of these are very critical in making that decision what to do next.
I see. There are two very important strategies in your field. One is called active surveillance and the other is watchful waiting. Would you please explain what those are?
So, as I indicated, many men have prostate cancer that will never impact their life. And the older they are, the more likely that's the case. There are no randomized trials, unfortunately, which have taken men with good prognostic factors and randomized them into either careful watching them, that is, careful monitoring with the plan, if there's any change in the grade or the stage, to then immediately treat them, give the opportunity for cure, or to proceed directly to, let's say, radiation or surgery. There's no study. The closest is a study with much more, quote, advanced, locally advanced, in which those two were compared, and it showed some benefit in favor of surgery compared to watchful waiting. Now, first, definitions. Watchful waiting has traditionally meant to indicate, I am going to watch this man, and at some point, if the cancer spreads, we will give him hormone therapy. It's not going to really be either surgery or radiation therapy. It's going to be just watching it, because he may not die of his cancer. Why give him treatment? Active surveillance is just important, is the point active. I'm going to watch or survey this gentleman, but we're going to do it in a very rigorous protocol. Protocol not meaning research, although we are monitoring ours because it's important. People want to know the data. But I will see that individual every 3 or 4 months. I will look at the PSA numbers. I will perform a rectal examination to feel if there's any alteration, change, any hard area in the prostate. And importantly, every year, I will at least offer a prostate biopsy. So for the first couple of years, I will do it. Why? Because the initial biopsy, well, let's go into the strict criteria. The criteria for active surveillance in my protocol, and not that much different from the other centers that are actively accruing men for active surveillance, or even general practitioners who follow this as an alternative, are only Gleason 6, only individuals who otherwise would be a candidate for surgery or radiation or some other curative approach. Otherwise, it's watchful waiting if there wouldn't be a potential for cure. And importantly, I would like 2 or less biopsies positive, and no more than 30% or 20% of the individual biopsy being positive. So as much as possible, I want to make sure by the biopsy information, as well as the PSA being below 10, and the Gleason score is mentioned, that they are low-risk prostate cancer and low volume. And with that criteria, they should fit into that category.
Interesting.
So that's our active surveillance program.
So who fits into the watchful waiting group?
Again, 80-year-old gentleman that his PSA was 15, someone did a biopsy, and you say, well, hormone therapy could be instituted, or radiation is a possibility. He says, you know what, let me just be monitored. I just do not have active treatment at this time.
I see. And what percentage of your patients do choose active surveillance?
Well, I have a very large cohort. I have published already 250 men with active surveillance, and only 30% with an average follow-up of only 4 years have been treated. No patient has died on the active surveillance protocol. There are 3 men out of approximately 60 who have been treated. And usually it's either surgery or radiation. There are 3 men who at the time of surgery seemed to be free of cancer, but then their PSA went up a little bit. They've all received radiation. No one has metastatic disease. Again, no one has died of prostate cancer. I don't think any of them will, ever. Because we're pretty selective who we start. And the key thing, 70% of these men have so far not been treated. Some for up to 10 years follow-up.
I think psychologically it can be tough not on the patient but on the significant other to know that there's cancer.
Exactly. There are several factors that have to be taken into consideration with active surveillance. Number one, they have to understand that many men have this cancer, prostate cancer, which before the PSA and before our biopsies being so forth would never have been found. Die of something else. That's the great majority. So that's an important fact that they have to understand, because everyone's fearful right away. And then because we've accumulated this data, and it's not only our institution, there are about 5 institutions around the world that have published their data, they're all in line. About 30% have been treated. But you have to continue with this monitoring. Unfortunately, it does require a periodic biopsy. Maybe in the future, MRI or some other test will allow us not to have to do an invasive procedure. But the trade-off between a biopsy and its morbidity and surgery or radiation is not insignificant. And mainly it revolves around erectile dysfunction as the side effect that might be associated with treatment. Not everybody, but it's a risk for some people. So, for example, let me give you a perfect example. In fact, just today, a physician came up to me in the hall, and he said, oh, I want to make an appointment with you. And I said, what's going on? He said, a couple of weeks ago, my PSA was 5. I had 10 biopsies performed, 10 individual biopsies. One of them had 1% of that biopsy with the lowest grade prostate cancer.
Right.
And of course, here's a physician, but yet, knowing all this information, he's nervous about it. He's already seen the radiation oncologist. Fortunately, he hasn't gotten any scans. He knows he doesn't need to do that. And I told him that, please look at our data on active surveillance. I'll be more than happy to discuss that with you. And I think he would be a perfect candidate for active surveillance.
I agree. Is there any way to alleviate difficulty urinating aside from surgery if someone has prostate cancer?
Well, yes, medication. I mean, there's 5-alpha reductase inhibitors. There are alpha blockers that can help avoiding. And the surgery can simply be a transurethral section of the prostate, which is a pretty benign procedure if it warrants any surgical method. And then, of course, later on, if you reduce testosterone, then the prostate will shrink much more than the 5-alpha reductase inhibitors, and often that will relieve their symptoms.
Right. Thank you so much. Thank you for watching. We hope this has been educational for you.